Hello, everybody. My name is Dr. Freddie Garcia, and today we're joined by the amazing Dr. Lon Kalapp. We have a webinar for you guys, and today's topic is going to be spinal decompression and Stimpod, which is pushing out transcutaneous pulse radio frequency therapy. Dr. Kalapp is a personal friend of mine and an amazing colleague. He is a doctor of chiropractic. He also has his master's degree in clinical neuroscience, which is not a small task. He has Dr. Kalapp, is it 27 years of experience?
27 years.
27 years of experience. And he's also doing coaching for those who are looking for ways to expand and grow their practices, both clinically and financially. So, if you, as a resource, he's incredible. I've seen him successfully run many different types of practices, which has always been an incredible learning experience for me. One of those styles being decompression. So we thought it was very fitting to bring you on and to have you talk about the integration of spinal decompression and Stimpod. So that is the task for today, Dr. Kalapp. Are you suited for the task?
Absolutely.
All right, Dr. Kalapp, here's how this is going to work. I'm going to disappear off the stage. I'm going to let you present, and I'll be back at the end, and we'll see if anybody has follow-up questions, and then we'll go from there. Sound like a plan?
Sounds good. Let's do
All
it.
right, have a great presentation, Dr. Kalapp.
All right, great. Hey, happy Friday, everybody. Getting excited about Thanksgiving and having some really good food. All right, so here's a little table of contents, and let's get started. Now, I do apologize because I realized I haven't had a current headshot in 5 years. So I promise next time I'll have some new ones because I've decided to just go all gray. Now, I'm a California native, born and raised in Southern California. I've been practicing for 27 years. I went to LACC. I just can't believe how fast it's gone. Obviously, I'm a chiropractor. I got a master's in clinical neuroscience during COVID. And then I got my diploma in American Board of Chiropractic Neurology, took my boards, I think, in 2015. But I graduated from chiropractic school in 1997. I'm also the founder of the Kalapp method. It's just a novel approach in developing and improving cash-based practices. That's kind of my specialty, but I can also work with insurance-based practices and hybrids of both. So I have a lot to say about decompression. So let me explain. When I'm talking about it, I don't want to come across as this is the academia. I think we all get a lot of that. I want to come as someone who's in the trenches practicing. Although I just sold my second practice, I was working for the gentleman the last 2 years, and now I'm done doing pretty much full-time consulting. But I do a little bit of side practicing, and my practice, the last one I sold, consisted of 3 different types. I had a very large personal injury practice. I had a neck and back pain where we specialized in decompression. And then I had my neurology cases, and I would accept about 6 cases per month. So I'm going to talk to you about some of the academics between decompression and Stimpod, but then I'm going to try to throw in some practice management things so you're better able to explain. Because at the end of the day, if you can explain the process better, it's going to be easier for the patient to go ahead and pay for the decompression. And people will pay for this, you guys, and I will share some numbers. So let's talk about the history of decompression. A lot of people aren't aware that decompression has been around for a long time. It was developed by Dr. Alan Dyer, and he developed the decompression in 1984, and it became out in the public, I believe, in 1991, and he started with a machine called the VAX-D. For some of you older guys, you remember this treatment, but it was all prone. Everything was face down. Now most of the decompressions are done laying on your back supine. So now, what is it? What is really decompression? So basically, it's a non-surgical approach to basically get a disc under control, either to reduce the disc and get it to suck back in, or at least getting people out of pain. I can't say enough about it. I think I was working for a practice, and then in 2004, we started doing decompression. So I've seen a lot of changes over the years, and I'm going to get into the way it was sold to us in a way. If I remember, it was a long time ago. But what happened was they're saying this technology is going to fix a disc. So basically, if somebody has a herniated, bulged, or protruded disc, it's going to get it to suck back in. And so that was a selling point. Back in the day, we used to do pre and post MRIs on all our patients, and we would pay for that, okay? Because obviously our packages were pretty lucrative. I think they were going for 6 to 8 grand per per patient per treatment protocol. And the treatments have changed. I remember when we first started doing it, it was like 3 to 5 times a week, and people were doing at least 24 visits. Now, what I've done in the last probably 10 to 12 years is I do a 16 visit package, and I can do it 2 times a week, and the patient does fantastic. Now, sometimes when you get into talking about decompression, sometimes the patient will go, well, gosh, I can't get in that many times. And at first I was like a staunch, you got to play by my rules or you're not going to be a patient. But I was nicer than that. But this is what I found. If people have a legitimate reason why they couldn't come in 2 times a week, I would say, well, can you come in 1 time a week? And they would say, okay, I can do that. And this is how I would explain it. And I think it's a good explanation from a practice management standpoint. So my office was in Rancho Cucamonga, California. And in order to drive to Las Vegas, if I drive the speed limit, I'll be in Vegas in 3.5 hours. If I drive 45 miles an hour, I'll be there in 12 hours. Will I get there? Will I get to Vegas? Yes, I will. It's just going to take longer. So that's how I was still able to treat these people at even 1 time a week. And it was effective. It just took longer. So that's a good explanation how you explain anything. If somebody's saying, if you're a functional neurologist and you're treating a patient, just explain it that way. You want to make these simple explanations so you're down at their level so they'll understand. People are kind of tired of the doctor that is so high in academia that they don't communicate real well. And fortunately, I'm from a middle class community, I mean, kind of the hood, you guys, it kind of is. And so it really taught me how to communicate at that level. But obviously, when I'm around like the Dr. Carricks and stuff, I got to step it up. But for the layperson, they really seem to appreciate it. So, what do you say when a patient comes to you and tells you he does decompression at home? I'm like, you do decompression at home? They're like, yeah, I hang upside down. And the first thing I say is, hey, if you're over 50 years old, you don't need to be hanging upside down. And they're like, why? Because you may blow a gasket. Okay, if you have high blood pressure, you don't need to be hanging upside down. But I'll actually kind of make a joke and make light of it. I'm like, oh, sir, so you hang upside down. What did that machine cost you? 150. Yeah, I wish I could only spend 150. Unfortunately, my machine costs $30,000. So they kind of get it. They kind of get it. And this is my explanation. I think this is a really cool explanation to explain to the patient, look, this is why traction is different from decompression. Okay. And this is exactly what I would do in front of the patient. So make sure you don't have any movement disorders or any tremors because it's going to throw the patient on. So what I do is I explain, okay, sir, Mr. Smith, you have a disc. So what happens is when we pull the disc apart, that disc only has so much range of motion. So once it hits the end range or the physiological barrier, okay, if I go through that, that's traction. And traction's wonderful. Traction does a lot of good stuff, but unfortunately for your disc, it's not going to be the answer. So this is why decompression is so different. So what we're going to do is we're going to pull the disc. And once we hit the end range or the physiological barrier, that machine is going to stop. Once it stops, it's going to stay within the physiological barrier and it's going to oscillate. And you do this in front of the patient. That oscillation creates a vacuum in the disc, allowing the disc to suck back in. Okay. Now, remember what I said at the beginning, we were kind of sold this technology that it was a way of reducing disc, but doing this for the last 20, 25 years, this is what I've noticed in the real world. That disc is only going to reduce 50% of the time. I don't mean 50% of the actual disc is going to reduce 50%. I mean only 50% of the time could you do a post MRI and it'll be gone. It does happen, but not like 80%, 90%. But this is what's interesting. Although we only get the disc to suck back in 50% of the time, I always felt that my treatments were 80% effective. So what does that mean? If they've got a disc bulge, I can't get the disc bulge to move, but they're 80% of the people don't have pain anymore. What's going on? Well, it's a good lesson. It's not always about disc. So this is an interesting story. When I first started doing these treatments, one of my buddies came in, he had a really bad disc protrusion, and we did the pre-MRI, and then we did the treatment. He was back golfing, 100% recovery. He did fantastic. At the end, he goes, all right, hey, I want to get a post MRI. I'm like, why? You feel great. He goes, I just want to see. Well, the post MRI showed absolutely no change. He was kind of mad. I said, why are you mad? And he goes, because you said that the disc was going to be gone. I go, hey, listen, man, you're playing golf, you're doing everything. Who cares? And I go, well, what was the other alternative? Having surgery. I go, so do you think you should have had surgery? He goes, well, they would have got rid of the disc, but they would have got rid of your disc problem, but you still had the pain because your pain was something else. Because what I find clinically, nobody just has a disc problem. It's always 3 to 4 different things. It's always going to be a facet imbrication, facet syndrome, sacral base angles too tilted up, so it's jamming at that L5S1 disc. There's so many other factors. Maybe it's post-surgical scar tissue, things like that. So let's talk about the different machines. I'm not going to put a bunch on here, but these are the big ones. DRX 9000. People like the DRX 9000. It looks really good. And if you can afford this, fantastic. But this is about aesthetics. The pulling mechanism is very similar to the other ones, but I think it's a good machine. It's just, if you're starting out in practice, I don't know if you need to spend this kind of money, because I'm pretty sure it's between $80,000 and $120,000. But again, the aesthetics are great. Another machine, SpineMed. I'm very familiar with SpineMed because this is the machines that we used when we first started doing decompression. I can't say enough about them. I think they look good. They do the neck and the low back. So yes, you could do the neck and the low back in decompression. Obviously not at the same time. Just not going to assume. Um, the only downside to these machines is when they break down, it could be a real big hassle. It could be pricey. Usually the warranty is a couple years, but what if you're in the 3rd or 4th year? That happened to us. And the SpineMed is very hard to find a technician. And again, the repairs are extremely expensive. So from my practice management view, I think this is the biggest bang for your buck. And I'm not getting anything for saying this, you guys. I just have used Triton, the Chattanooga Triton, for over 12 years, I think. And it does fantastic job. Maybe not as aesthetic, but at the end of the day, the patients don't care. They just don't care, because you're going to get this equipment no more than 15 grand, and you could probably find it as low as $12,000. It's basically going to do the same thing. And you just can't say it. I've been practicing long enough. I know it does the same thing. So again, a lot of the stuff I'm going to teach you guys is just from being in practice. All right. So warning, warning, warning. Things you don't pull. I literally get a call every other day from a doctor all over the country asking me, do I pull this? Do I pull that? Do I pull this? Do I pull that? So you should not use decompression on spinal fusions, whether it's cadaver or whether it's metal. You can't do it. Now, in reality, if it was my brother who had fusion, would I decompress him? Yeah, I would. Because if something goes wrong, he's not going to come and sue me. But if a patient has a problem, maybe a screw gets loosened, I don't even see how that's even possible, especially with the cadaver lab. That thing's not moving. You're just moving the other segments. But legally, you just can't go there, because if something happens, it's like giving a pregnant woman advice about something and she has a miscarriage. They're going to blame you. It's kind of the same thing. Infections of the spine, just don't even go there. Fractures, do not go there. Obviously, cancers, do not do the pregnancy thing. All right. Just don't do it. So things you can do, and this might be kind of surprising for some of you. Severe osteoporosis. I've never had an issue. This pressure of pulling is nothing, you guys. It is so minute that if you step out of a car, that force hitting the ground is a lot more than any force that can happen with decompression. Yes, I pulled osteopenia, osteoarthritis. My oldest patient was 95 years old. That was in a wheelchair. I got her into a walker and she was so happy. I constantly treat people in their 80s, 85s. I used to have a lot of them. Yes, you can treat spinal stenosis. All right. Why? What's a good explanation to explain spinal stenosis? So this is how I explain it. So stenosis, closing of the canal. What happens is you got the venous system that's on the outside. All right. So when you get stenosis, those bones are clamping down. And what happens is you get a stenosis, you get the venous ballottement where it will pull. Okay. That blood will pull and it'll cause congestion. So when we're decompressing, it's going to allow the venous system to just basically leave that area. So it's going to help with the stenosis. Okay. So yes, pull spinal stenosis. Obviously, it's fantastic for disc bulges, disc herniations, disc protrusions, disc extrusions. But let me make myself very clear. I did not accept a lot of extrusions, and let me tell you why. All right. It's because it's almost like pulling, say you have a little kid and they get gum in their hair. What are the options? You cut it out, or you put a little bit of peanut butter on it to get it out. So I will accept an extrusion if it's very small. If it's big, you guys don't waste your time because you're not going to get these people better. And I hope that analogy kind of helped. I know I'm talking kind of fast, but I want to get through everything. So protrusions, probably the number one reason why. Okay, we're there. But extrusions, just be very leery and explain to the patient, just be real. Listen, these are the toughest things to treat. All right. I believe you have a 50-50 chance, and put it in their court and let them make their decision, informed decision. Okay. I hope that makes sense. All right. Now we're going to jump. So let me talk about, let me back up. Sorry. All right. Let's talk about the treatment protocols. My treatment protocols, I did 16 visits 2 times a week for the duration. I charged before COVID. My cases the last 12 years were $4,800 for 16 visits. After COVID, I got a little nicer and my cases went from 35 to $4,000. And that's a good price point, especially after COVID. I signed up anywhere from, on a bad month, 10. I have signed up 30 in a month. Okay, because people realize that this is out there. Also, don't be nervous about everybody doing it. But if you're good, the cream rises to the top. All right. And if you need help in explaining that or even getting your dialogue down, it's really not difficult. We had tons of decompression in Rancho Cucamonga, but people came to me and I was very fortunate. Definitely, I think it's a little of an advantage having that neuro diplomate. Definitely gives you a little clout. But but yeah, and it does work, you guys. I meant what I said. 80% of my people do well. And I don't tell them 80%, but I'll say something like this. Listen, if I accept 100 people into my practice to do decompression, I feel very confident I'm going to help 80 of them. And people tend to get that. All right. All right. Now let's get into Stimpod and Algimed. So basically a non-invasive treatment for neurogenic pain. I'm going to tell you right now, for me to even talk about this, it's got to be a big deal. This is literally my favorite piece of equipment, and I'm very excited about it. I received this technology about a year and a half ago, and Algimed allowed me to just go run wild and test it on everything and see what it works on. And I'm telling you, it is a fantastic, fantastic piece of machinery. In the past, I've had the soft waves for $86,000. Nothing against soft wave. I love it. I've had PEMF. I've had all the bells and whistles. What's the nice thing about this is it's not going to cost you $86,000. This is a $5,000 piece of equipment. And I'm telling you right now, if I was on a desert island and I had to choose between laser, class 4 laser, which I did a lot of, soft wave, or something like this, Stimpod, I would pick the Stimpod. I literally keep this with me in my gym bag. And if I see somebody blow an elbow or something, I'm talking to them and I'm doing it. They always become a patient. Obviously I'm not shy, but I can't say enough. I've been in restaurants where the waitress has a brace around her arm, and I just said, look, do you get a break in a few minutes? I have this technology. I literally will go out to my car, grab it, and come in, treat her. She becomes a patient, and it works every single time. Also, I don't want to get into the academics. I am not an engineer. Yes, I'm a neurodiplomate, but I don't know everything. But yes, I know in layman's terms how to explain the Stimpod, because it's the same way I explained it to the patients. So basically, how is transcutaneous pulse radio frequency different than a TENS or EMS? And it's all written right here. But a lot of people look at it and they go, oh, it's a TENS. And I'm like, you can't compare it. It's like you're going to go to the neighbor's house, you're going to ride a skateboard, or you're going to take a Ferrari. It's like taking a Ferrari. Okay. It is that good. So the way I explain it is it's kind of the first of its kind, a way of getting a frequency, a specific pulse radio frequency that actually goes into the axon. And I tell my patients, think of the axon as a tunnel, and it's got all these chemicals, everybody remembers cytokines from COVID and all that. So you get these cytokines, you get all these things that cause hyper irritability of the nerve, and it just causes the nerve to kind of get pissed off. So what this does is it cleans house. It cleans house and gets rid of that stuff, and it makes that nerve. It literally is neural remodeling. There is no frequency out there that will literally remodel a nerve, because we want to do what? We want to get these people out of discomfort. We want to get these people out of pain. There are things that I have tested this on that hasn't been researched, but I've done it enough that I feel comfortable in sharing it with you. You guys, a 10 is going to help with short-term pain. EMS is going to get the muscle to contract to basically get blood to that area. This is actually going to penetrate the nerve and help remodel the nerve. And then there's going to be growth factors that are laid down, and it's going to have a positive impact on a mitochondria. You know, we've all heard this stuff, but this is what? Somewhat of a solution to this problem. This isn't a quick fix. This isn't a short-term thing. That's why we use it for the peripheral neuropathies. I believe the future of peripheral neuropathy, if you're not using Stimpod, you're not really treating neuropathy. Because, and I treated peripheral neuropathy for many, many, many years. Okay. And I'm not afraid to talk about that stuff. Also, there's some good research done on Algimed that did research on peripheral neuropathy. And I think that's good. And we can get you this information later. Matter of fact, if you want the slides, we can send them out. We can figure that out. All right. So here's about the wordiest slide that I have. And let me try to move my box a little bit. And what's funny is I'm like the worst technology guy in the world. So I'm learning as I go, but I'm going to read it real quick. Non-invasive electromagnetic therapies have been tested and investigated for the treatment of common pain conditions, including sensory and motor neuropathies. The clinical efficacy of electromagnetic therapies in generating analgesic effects have been proven, and is one reason behind the growing interest in electromagnetic therapies as a therapeutic solution for pain syndromes, including peripheral neuropathy, diabetic peripheral neuropathy. All right. For example, 2 clinical trials on individuals with diabetic neuropathy have applied transcutaneous peripheral nerve stimulation using Stimpod NMS460, respectively, and obtained significant reduction of DN4 and VAS pen scores, visual analog scale, emphasizing the role that electromagnetic therapies might play in resolving pain syndromes, including diabetic peripheral neuropathy. While the underlying mechanism of electromagnetic therapies is still under investigation, it is thought to be involved with pain modulation, nerve excitability changes, cellular energy production, cell metabolism enhancement, and gene expression changes. Stimpod pulse radiofrequency therapies have been shown to play a crucial role in corrective readaptation of neurological pathways, and as such, it may have a positive impact on patient outcomes as a therapeutic solution. And I'm here to tell you, as a practitioner of 27 years, it does exactly that. And actually doing some videos to show you what's going on. There we go. All right. Sorry, it froze for a minute. So let's get into the things we can. Now, this is things that I have treated. So I'm not going on record to saying Algimed says you have success with this. No, no, no. Dr. Lon Kalapp says you can have success with this. So I've treated a lot of neck pain, acute chronic low back pain, and that means acute chronic neck pain as well. Great results with drop foot. Guys, I've treated post-COVID drop foots. I've treated obviously severe low back pain, strokes. So what is the thing? Some of you neurodiplomats that are on here, you guys are aware that we have a treatment called RPSS, repetitive peripheral somatosensory stimulation. You spend $15,000. It's a Caldwell machine. I have one. I'll throw it away. I don't need it anymore, because the Stimpod is RPSS on steroids. And I think the reason why we're able to get such drastic changes so fast is because it's having a really awesome impact on the maps, the somatotropic maps. Okay. So definitely we're changing that. So for example, if I have patients with vertigo that have a balance issue. They say, wow, I'm really wobbly. I'll do a gait protocol using the Stimpod. One visit, they're like, I don't know what you did, but I'm more stable every single time. That's extremely powerful, you guys, extremely. So what's really happening is it's changing those maps instantaneously. So I use it for balance disorders. I use it for traumatic brain injury, V1, V2, V3. We're going to get into the brainstem, okay? We use it for trigeminal neuralgia. What else are you doing for trigeminal neuralgia? With the gamma knife? Okay, it's too invasive. Okay, and one thing I want to explain right now is Stimpod is non-invasive. You're not hurting anybody. I've never hurt anybody. And I've done it hundreds of times on people. Bell's palsy, fantastic. Dysautonomias. I think everybody post-COVID has a dysautonomia. Fantastic for dysautonomias. Headaches, best thing I've ever seen for headaches. Standard, I know you guys have all seen the Adam Harcourt videos on migraines, but I'm telling you, and it's the easiest treatment. I can get rid of a headache in 4 to 6 minutes. Anxiety, yes, it's a form of vagal nerve stimulation. Works fantastic. Vestibular issues, I use it on a ton. Obviously, peripheral neuropathies, fantastic, okay? So now I'm going to show you guys some videos and I want you to see the patients. And you guys, I'm not a photographer. These aren't the best examples, but I think they're decent and you'll get something out of it. So let's start with this one. Go ahead and start. Okay, hey everybody, so this is my treatment for low back pain and it can be sciatic as well. So the first thing I do is I do their exam. Obviously you do your exam, have them go face down. I have them pull their shorts down a little bit, come a little closer, and I want you to get right in this area. And what I do, whether you palpate, do whatever, it doesn't matter where the disc bulge is. What I like to do is I like to palpate the superior cluneal nerves, because one of these is going to be on fire 9 out of 10 times, all right? Now say it's the right one. All right, so remember the branch, the sciatic nerve branches, intermingles and comes down. So that superior cluneal nerve, if this one's on fire, all I do is I put the ground on the left superior cluneal nerve. I hook it up, and this is the ground, remember that. And again, I'm not a videographer, so forgive me. And then what I do is I put the gel right there on that spot. I make sure that the machine is on 2 hertz. Okay, it's on 2 hertz, and then I bring it up to 15. You start at 15. If they can tolerate it, you go up to 30, and most people can tolerate the 30. And I'm going to turn it off because I don't want to zap them. All right, so all you do is you put the stylus right where the gel is. You're going to do it for 2 to 3 minutes. Now understand, when you're doing this in an exam, you're not telling them it's a treatment. You're telling them it's a nerve test, and you're checking out the nerve and seeing how it's functioning. But the good news is when I'm done with this exam, you may feel some relief, but it's not permanent. You have to explain that to them, okay? So let's get a little closer right here. Now, if they got really bad sciatica, you do it here for 2 minutes, and then you come down, you put the gel on the popliteal fossa, you could do it there for 2 minutes. I personally don't use the popliteal fossa. I use the common peroneal nerve. So I put it right on the common peroneal nerve, okay, because that's going to be a branch of the sciatica as well. And you're going to make sure that there's gel on there, okay? You are going to experience some tympany, but understand the way the frequency is made, the tympany really has nothing to do with the healing process, okay? It's the pulse radial frequency that's going to get into the axon, and I'll explain that during the webinar. Also, the reason why they put the tympany in the frequency is so you know where the nerve is, because remember, this is about neurogenic inflammation. So there's certain things, like I have a bad elbow at the radial head. This doesn't really help me with the radial head, but it helps me with a lot of other things, okay? So again, there's so many protocols. There's different ways to skin a cat, but I find that this has worked for me for the last 1.5 years and people are happy. One other thing. Also, you could put the stylus, you could put the ground next to the sacrum, and you can also use the stylus along the sacral, the border of the sacrum. Some guys do that. I personally have never really needed to do that, but that's totally fine, okay? I hope this video helps. Thanks, guys. Hey, how you doing? This is Dr. Kalapp in Rancho Cucamonga. So I have one of my patients here that came in with severe low back pain. A lot going on, huh?
Yeah.
So you've been here about 4 visits now?
Yes, sir.
How you feeling?
Great. A lot better.
Okay, what's better?
My walking, my lower back pain, whatever that
So
machine
he
is.
suffered with drop foot. So not only am I treating his low back, but basically what drop foot is if you think of someone with a stroke, they can't lift their toes up. So when they walk, they drag, so you can't walk real well. And I have some very new technology called a Stimpod. And the Stimpod uses something called pulse radio frequency. So we put a current into that, and it's a way of tricking the nerve to activates the brain. And guess what he can do now? Point to his foot. Doesn't look like a whole lot, but when he couldn't do that before he came in, you could see why he couldn't walk. So now I'm pretty excited. We give us another 4 visits, I'll make another video.
This is great.
Yeah, thanks, I appreciate it. I'm gonna show you the Gait protocol, and basically when I'm talking about anybody with drop foot or the fact that you have that patient that's had a stroke. So what you do is you put the ground on the other side here around the common peroneal nerve, and then I'm treating the right side, and all you do, come around here. Put it right along the side. I started off on 20. And remember, this has got to be at 2 hertz. This stays at 1 millisecond. And then you got to find the area where it's going to cause it to jump. His foot. See his foot? That's what you want. And then have him hold it. Go and hold that for me. And you're going to do that for 2 minutes. You're going to do both sides. Okay, and then you're going to do the same thing, but you're going to do it here, where you're going to put the stylus here, put the ground here. Now watch what I do. Lift your foot up, your toe up. There you go, like this. Lift it up and resist. Not this one, just this one. You have them resist, because it's going to send a message to the brain, and you only do it for about 10 seconds. Do that a couple times when it's here. When you're doing the stylus here, you have them push down. That's all it is. 2 minutes, 2 minutes, 2 minutes, 2 minutes. Okay? All right, any questions, call me. Thanks. All right, so this is the Gait protocol. So what I did was I put the ground on the opposite fibula head, and then I actually have the patient do it themselves. And then you can see what's happening, the foot twitching. So now what I'll do is I'll have them go and lift your toe up. Lift your toe up for me and resist. Lift your toe up and resist. Lift your toe up and resist. You do this for 10 seconds. And then relaxing. You do that about 2 or 3 times. And what that's doing is that's putting information in the opposite cortex, and it's going to remap the maps. So her brain's going to have a better representation to be able to walk better. And you agree it does work, right?
Yes, it does.
She notices after every treatment. And do you mind if we get into your history a little bit?
I don't.
So she basically had neck fusion, and since the neck fusion now has balance problems and has gait issues, so that's what we're working on. And do you think the machine works?
It does.
It works very well. And she has a lot of spasm in her neck, so we can't decompress her. So what we're doing is we're doing the Stimpod right on here on the brachial plexus on each side. Okay, and we're using it on that area. So she's doing both traps, and we're doing both fibula heads. Now also, she doesn't quite need this as advanced, but severe drop foot, I'll also put the stylus on the posterior tibial nerve, which is down here, and then I'll put the ground over here. Okay, now you're doing this for 2 minutes each side. Okay, that should be enough. Okay? All right. Any questions, let me know.
That's what I did.
All right. So we got through it. So again, take a minute if you guys want to scan these, and you can look at the videos at home. And these are real patients, wonderful people. I actually think it's a good idea if you do have a Stimpod that you do a video before you do it and then after, and you're going to notice every single time this will make changes very, very fast. Now, is it going to fix a neuropathy in 3 visits? No, but you're looking at about probably 8 to 12 visits. I actually used the Stimpod as a testing device when I mentioned it in the video, but that video kind of got messed up. So what I would do is I would do my examination, and then I would have the patient, Amy, then I would have the patient lay down, palpate, feel their pain. And if you guys realize when somebody has back pain that they're going to have discomfort on the superior cluneal nerves, which is right above the buttocks, if you press down and they feel pain, then put the Stimpod over it, and it's going to help them with their pain quite a bit. All right. So, all right. So a lot was said today. I try to do it in a timely manner. Sorry about the videos. So this is information to get a hold of me. Matter of fact, if you guys want to email me, there's actually something I developed. It's a way of explaining the different types of disc problems. What I do is I get a dry erase board, and I learn how to do it upside down in front of the patient. And this pays dividends. So if you email me and say you want it, I will send you the video. Okay. And it's just a way of drawing the different discs. And it really, really convinces the patient that you know what you're talking about. And they're going to look at you and go, how can you ride upside down? I'm like, I've been doing this for 27 years. So it's pretty powerful. Okay. So this is my cell phone number. If you guys need any practice management advice, I'm here for you. I'm here. Even if you just have questions, I'm here. Anything I can do to help you guys, I'm here. Thank you so much for listening to
All right.
me today. It was exciting.
Dr. Caleb, we
Yes.
have one question here. The patient
Okay.
says if the person had a stroke and they have drop foot on one side, do you still treat both sides, or do you only treat the affected side?
I would treat both sides because you're going to get a 90% and then a 10%. It's like the person who breaks their arm and he's in a cast, you still work out the good arm because 10% is going to go over to the bad arm.
Yeah.
That's
And
the
since
way
there are no side effects, I guess you can get away with that, right? So better safe
I,
than sorry.
you
All
totally
right.
can.
Awesome.
All right.
Well, Dr. Caleb, thank you so much for sharing with us your experience in regards to spinal decompression and how to incorporate the Stimpod into that. It's pretty cool. Thank you for sharing the videos as well. I think it helps people to see what is possible. I think there's conditions out there that patients have not, or that doctors have not tried treating yet. And I think showing videos gives them permission to do that, and then they can get some success. Um, Somebody's asking, what does treatment look like for somebody with neuropathy?
So neuropathy, I'm going to probably do a protocol of at least, I wouldn't do 8 visits. I would do 12 visits. And I would listen. This is the nice thing about the Stimpod. You can use it in your office. And what's nice about in your office is you have the patient actually hold it themselves on that area. Obviously, if it's a low back problem, they can't reach around and hold it on their low back. But I make the patient sit down and I let them put it on the common peroneal nerve and then the posterior tibial nerve. And this is practice management on steroids because I have my clients by five. Yep, spend $25,000. What they're going to do is they're going to use 2 in the office, and then they're going to rent the other 3 to the patients because if somebody has really severe neuropathy, they're going to be able to do it at home twice a day. Now, if you are going to treat neuropathy, obviously you're going to have to get a hold of us, and I need to be very specific because sometimes people think doing more is better. And I personally, in my clinical experience, you do not do 10 minutes at each site for peripheral neuropathy. You do 2 to 4 minutes max. That's it. That's all they need. Because if you do more, it's almost, I'm not saying it's cooking the nerve, but in layman's terms, it's you're overcooking the nerve and it's just too much. And it's not going to cause pain, but they're going to almost feel like, wow, my legs feel like logs. They feel kind of tight and swollen. They're not, but it definitely has an impact on that. So that's what's nice about this protocol, you guys. It's fast. I can treat a migraine headache max 6 to 8 minutes. And it's going to be, if it's during the middle of the migraine, 50% gone. If I get it in prodrome, I find 100% they're gone. They're able to drive home and do all that stuff. So again, very powerful. Hey guys, I love this thing. It's my favorite toy right now, and it's going to be for a while. So there's my story, and I'm sticking to it.
Okay, awesome. So there's Dr. Caleb's information, drcaleb@yahoo.com, and then the Caleb method if you want to contact him or maybe get some of his services in regards to growing your practice clinically and financially. I'm Dr. Caleb. Thank you again for your time.